Hello, everybody, and welcome to this episode of Infection Control Matters. And I'm delighted to say our guest today is one of our most popular invitees. That's Dr. John Otter from Guy's and St Thomas's. Hello, John.
Hello, Martin. I'm blushing. You can't see me, but I'm blushing.
Well, you're going to blush even more in a minute. I'm going to be effusive. I bumped into John last week at the Federation of Infection Societies conference, where I have to say he was still on paternity leave, I think. So congratulations there. And John was delivering a lecture, which is actually an award. He was awarded they call it the Early Career Award, and we were joshing about it a bit. But actually, the award from the Healthcare Infection Society is in recognition of the fantastic work done in the early period of someone's career, with the expectation there's plenty more to come. And I think that's going to be absolutely the case. So if you don't know John, he's the Director of Infection Prevention Control, and he's also a consultant clinical scientist at Guy's and St Thomas's. John's worked also at Imperial. He's worked in industry. He's worked in academia. And he also has a new venture with Dr. Phil Norval called IPC Partners, who actually are very interested in providing high-quality education to people. They produce webinars and journal clubs in conjunction with professional societies like the Hospital Infection Society and the Infection Prevention Society. Is that gushing enough for you, John? I think probably that would be.
Thanks, Martin. I mean, we've got to talk about the early career part of it. I mean, my family was so proud of me. They really made a fuss of me, and they were all giving me lots of positive vibes until they found out the name of this award. And since then, I just haven't lived it down.
No.
So I've been a laughing stock on my own home, but no,
Yes.
I am genuinely proud to receive it. It's a real honour.
Well, you should be. It's well deserved as well. Now, what we're going to talk about today, John has had a couple of papers recently and a poster at the FIS conference as well on the topic of Candidiasis auris. And one of the first ones I want to talk about is the paper published in the Journal of Hospital Infection, and it's looking at wastewater sampling for C. auris. Now, to my knowledge, that's not been done in the UK before. So can you explain why you did it and how you went about it a little bit?
Yeah, so I think the concept of wastewater surveillance is generally on a much bigger scale than we were looking at applying it. It's usually done in a municipal wastewater surveillance plant where you get, gushing waste from a whole community network that goes to this plant, and you identify target organisms and look at the quantity and kind of work upriver to see where they may have come from as a kind of community level surveillance. It was championed during COVID, but it was in place before then as well. We wanted to look at whether the wastewater surveillance concept could be applied much more locally. As anybody who has ever tried to take a sample from a patient for Candidiasis auris will know, it's really difficult, actually. It's difficult to know which body site to sample. It's difficult to know whether you're going to get false negatives, because often you feel like it's there and subsequent evidence suggests that it was there, but it's not. It doesn't manifest in the method you're using because the patient has got a low level in their gut or on their skin or wherever it's being colonized.
That's such a good point, because any sample like that is only as good as the actual bit you touch, isn't it? And, it depends on the quality of the specimen, who's taking the specimen. I can remember asking for perineal swabs for MRSA back in the day, and the staff would do groin swabs because they didn't really like going down to the perineum. So we missed a load of people. So I think that's a really good point, that it is difficult to get high quality screening specimens unless people are well educated. Sorry, I've interrupted you.
No, it's okay. And you've been talking about perineums now, or perineia.
Yes.
Is that right? Is perineia the plural? Anyway.
Okay.
There's an interesting study published ages ago that shows that staff aren't actually always clear exactly where the perineum is, which isn't great, really, is it, when it comes to sampling? You've got all the uncertainty around patient sampling. And on top of that, the problems around who to sample, who do we screen? How do we get a risk-based screening method in place? Because we can't screen everybody realistically in terms of cost, and in terms of the extent of this organism in the UK, it wouldn't be proportionate to screen everybody. But do we want to screen 30, 40, 50% of our staff? If we screen our own readmissions, that's probably not a goer. So the idea was, could we use wastewater surveillance on a local level to say, oh, this ward has flagged positive in the wastewater. Now let's use that as a trigger to go and sample the patients and work back that way. Mm-hmm. So that's the general concept that we were trying to test.
Okay. Where did you actually take the sample? Because getting access to the hospital sewage system, I suspect, is not that easy. So how did you go about that?
Yeah, so we looked in a couple of different places. So we wanted to do kind of hedge our bets really in terms of the areas of the ward that we sampled. So we looked at a sluice, a macerator, and those two sites combined just as a starting point.
Yeah.
You might want to sort of dip into the main waste pipe coming away from the ward, but that's tricky to get to.
Yeah, that's
and
what
I think
was
the
thinking,
reality,
really.
but the reality is there probably isn't a single waste pipe exiting the ward. As you know,
that's also what I was thinking, because you've often got paired wards. So where's it coming from at that point? Yeah. Okay.
And nobody knows. You haven't even got good schematics. We know this from our work with Pseudomonas and Legionella. No, it's a patchwork of pipes, so it's quite difficult to know where to sample. So we felt that looking at those two areas would be a good place to start.
Okay.
And we combine that with a point prevalence screen of patients on 9 wards in a single block where we had an ongoing outbreak of C. auris. And I was pleasantly surprised, really. We found a pretty good correlation between the wards where we found patients to be positive, colonized, and the wards where we found the wastewater to be positive, colonized.
Did you know that the wards were there were patients who were positive on those wards before you did this, or did that spring up? Actually, we may have people on here who are positive.
It was a mixture of the two. So in the patient screening, most of the positives we found were known positives, but there were a couple of unknown new positives that were detected through the point prevalence screen, which was the reason for doing it, because we were trying to understand whether our screening approach was picking up the positives, and it turns out it wasn't completely. So it has resulted in some changes in our patient screening protocols as well.
Okay. But you also, you note in the paper that you found an area where it was positive in the wastewater, but you couldn't find a patient who was positive at that time. Is that right?
Yeah, exactly. I'm not surprised by that at all. I mean, no. I believe the wastewater positive, it's difficult to think of that as a false positive. I suspect we had a patient that was brewing it, or a patient that, had a true positive that was not detected by the sampling method we were using.
Yeah, or they might have had somebody who went the day before. The question then is, how long would a sewage system remain positive? Is it a gift for life? that's also, because wastewater pipes get colonized with biofilms form. What's the longevity of it? That would be interesting to know, because I don't know that anybody's looked at that yet.
That was another important reason for doing it, because my suspicion was that we'd find all of the wastewater samples positive, because we've had C. auris positive patients on all of these wards at some point in the last year or so.
Oh, right.
We know that you have biofilm coating the pipework in the areas you can't see. We know from work with CPE, etc., that it lasts for a long period of time. So I was sort of pleasantly surprised that we did find the negatives that seemed to correlate with the wards that didn't have live patients. I don't mean live patients, you know what I mean?
Yes.
Patients with C. auris.
Things are not that bad at Guy's and St Thomas.
Yeah. Patients with C. auris who were on the ward at the time of sampling, I should say.
Oh, that's actually quite interesting, though, isn't it? Because you can show, therefore, that there's a hope that sewage systems do become negatives. That makes this sampling method actually quite useful, as opposed to if it's the last patient you knew was on there a year ago and it's still positive, then it's interesting, but that's probably about it. Okay, so that's useful, I think. And the second one was actually you looking at a case
Martin,
control. Go on.
No. Can we just talk about molecular versus culture-based methods as well? Because that's a big part of this paper and a big part of the conundrum at the moment with C. auris detection methods.
Yes.
So we did both culture-based detection and also molecular detection from the wastewater. And it seemed that the culture-based method slightly undercooled true positive, and the PCR method slightly overcooled true positive. Based on the patient positive. So which is better?
Yes.
I'm scratching my head. I don't know.
No. Okay. Yeah. Is it better to overcool? I don't know. I mean, it's a tricky one, this, isn't it? Because, if you get a load of C. auris in your organization, you and I will be probably quite concerned about it. And it's possibly an indicator there's plenty else going on. But in the vast majority of cases, and you showed this in your paper, there's no extra mortality, no extended stay. If I was a manager, I'd be saying, you want to spend potentially all this money. So what? No, people aren't actually getting ill. That makes it slightly more tricky, doesn't it? Because you're arguing maybe for a bit more resource to do some molecular work. And what are your thoughts about that?
Yeah, I think you might show that in the short term, you see little impact in individual patient outcomes. But I think if we look at a more regional level, national level, population health level, C. auris is a bad is a bad thing and is going to result in consequences over time due to the just general squeeze on antifungal susceptibility. And I think if you look at the countries where C. auris has become really established, that's exactly what's happened. The initial phase is not much clinical impact. And then all of a sudden, your fungal bloodstream infections, your candida bloodstream infections that were albicans have become auris, and they're more difficult to treat. And then you start to see some impact further down the line. So I think that's why public health bodies like UKHSA are so concerned about this.
Yes, and rightly
this trend
so.
in the UK. And exactly, rightly so.
Yeah, but that's a key message we have to get over to people. It's not possibly got the greatest clinical impact now, but what's coming is much more of an issue. Okay, the other part is the poster you published, which I thought was quite interesting as well, which is looking at a case control study of people with C. auris in the organisation. Can you talk us through that one a little bit?
Yep. So we had an opportunity to do a case control study based on an outbreak we had at Guy's and Tommy's, which is still ongoing, although we're seeing many fewer new positives than we saw at the start of it. So there's some semblance of control going on. So we wanted to run a case control study because, as you've alluded to, there's some suggestion in the literature that C. auris has really significant and immediate clinical impact in terms of length of stay, in terms of patient mortality. So we looked at the first, I think it was 60 odd patients with C. auris colonization and matched them 2-to-1 with patients who were in the similar wards at the same time, who were around the same age. And that matching process, I think, was really important and probably explains some of the outcomes, because we didn't see that patients who were C. auris colonized stayed longer. The length of stay was comparable. We didn't see any increase in mortality. We didn't see any impact in sort of clinical features that you'd be concerned around with a fungal infection. And I think that's because of the way that they were matched, and perhaps suggests that the way that patients were matched in other studies was not adequate.
Yeah, okay. I mean, the good news is that lines didn't seem to be associated with C. auris, which is actually very good news for line care and other invasive devices as well. But it was often the more external interactions with patients that seemed to be a bit more of a risk. John, can you talk about that number one on that one?
Yeah, so I don't think this means that we can breathe a sigh of relief and that devices, especially vascular lines, are not a problem with C. auris, because most of these patients were colonized, not infected. I think if we were looking at associations with C. auris infection,
that would be different.
Then I think we'd begin to see the lines, the drains, the airways becoming more significant as a risk factor. But in terms of sort of colonization acquisition, we didn't see association with those devices. But what we did see is an association with exposure to Dopplers, and that was quite a significant finding for us and prompted us to go Doppler hunting in the organization. And it turns out there's a lot of Dopplers and a lot of different types of Dopplers all over the place.
Yes. I was going to ask that. Are these individual departments own Dopplers, or do people go to a central area to have their Doppler performed? Or, as you say, if they're all over the place, I mean, they're very useful devices. I can see why they're everywhere.
Because of the relatively small sample size of the study, we couldn't stratify by individual Doppler type. We didn't have that information. So we couldn't look at sort of handheld mobile ones or the Dopplers that a patient may go to. So it was just a broad association. But I think it probably was quite a helpful finding for us, because it reinforced our messaging to say, look, shared medical equipment is a really important risk factor for C. auris. Look at the Oxford study.
Absolutely.
Look at the thermometers.
Yeah. I mean, what I thought was absolutely fascinating is people, I don't think, even on our own field, still aren't getting that, because I remember the first question you put up at the FIS paper was, which of these areas that we work in has the most reliable and the most clinical evidence behind it? And everybody went for hand hygiene. Yeah. And surface disinfection was far further down the list. And I mean, I know you asked for everybody to send you all of the RCTs by email, but I suspect your email basket, bulging though it is after a period off, hasn't actually had too many, and they still aren't quite getting. And you know, as you said, the Oxford study showed it with the temperature monitoring probes. Plenty of others. Shared medical equipment still isn't getting the attention, is it?
No, absolutely. And I was a bit surprised. I thought that poll may say something different, but it suggests people still haven't quite caught up with the data around surface contamination, especially the shared medical equipment. I mean, look at the clean study with Brett's group from Australia. It's pretty compelling, isn't it?
Well, I would have thought so, but I mean, we don't audit it. We'll audit hand hygiene and get unfeasible results, but we don't audit that sort of equipment, which surprises me a bit. Are you going to do anything with the Doppler? Go on. Sorry.
We have started auditing that for that exact reason. So we've just launched some shared medical equipment decontamination audits. Right. That the IPC team are beginning to run in response to this outbreak and these findings. And It's one of those things that I'm thinking, well, why weren't we doing this before?
Yeah.
So it's almost repurposing some of that time we've been using for hand hygiene auditing, which is obviously important, and shifting that in a different direction.
Yeah. Okay. I mean, hopefully automated will come in and help us with hand hygiene, but probably not with shared medical equipment. Are you doing anything with that Doppler finding? I mean, it's I know you've been off, but who's decontaminating the Doppler device? Have they got the right gear, et cetera, et cetera? I suppose is something you're looking at.
Yeah, we had a bit of what you might describe a Doppler summit where we got together the teams, and we actually identified a clinical nurse specialist whose role was essentially for Dopplers. Wow. So you've got all these roles and this expertise in an organization that you don't necessarily know about. So we were able to pull that together and work out where we do use Dopplers, what the journeys of them are, how they're disinfected or how they should be disinfected, and use it as an opportunity to reinforce best practice. We did do some sampling. We found a contaminated Doppler with Seoris, so it sort of reinforced the epidemiological finding.
Yeah,
I think our Doppler disinfection is in a better place. Is it perfect? It's not perfect.
No,
it's a really, really challenging problem.
Yeah,
to make sure that all these many items of shared medical equipment are disinfected properly.
I mean, it just shows though the value of doing a small case control study to actually work out what potentially is going on, and you nearly have 4.5 times risk if you had a Doppler. Although interesting, I noticed imaging comes up as a bigger risk as well. Like MRI was nearly 3 times risk, echocardiogram nearly 2 times risk. Do you think imaging departments are actually getting the decontamination of equipment between patients or even the surfaces around? Because often they're on a very tight schedule to get people through departments. Is that something we should look at a little bit more?
Yeah, I think we should. It's quite hard to know what to do and how to action that. I suppose the possibility that with the imaging departments, with the Dopplers as well, whilst we did try to control for confounding variables, we may not have done a perfect job. We may not have had the data to do that. So it could be that these are sort of red herrings, and it was more about the patient population that tends to have more imaging or tends to require more Doppler use that ended up Seoris colonized. But because we have an electronic patient record, we did have a lot of patient variables in there. So I think it probably is pointing to genuine risk points that we need to look into some more.
It's certain to look at, isn't it? It's opportunities to improve, I think. Radio John, thank you very much. I'll let you get back to your email mountain. Really appreciate you spending the time with me on your first day back. And always good to speak to you.
Thanks, Martin. Always good to talk to you too.